getting the air into the lungs, because once again, the scar tissue or whatever tissue that is less compliant, that has displaced the pulmonary tissue, is not going to yield as readily. There is another type of condition in which the patient has adequate compliance. If anything, the compliance is above normal, but they lack elastance. This might be manifested in a patient with emphysema, for example, where the individual alveolar sacs have coalesced. And instead of having lots of little alveolar sacs, you have a large chamber of air. And the problem this patient will have, again, they have no trouble breathing in, but they may have to lean on furniture or lean on a wall, do whatever they can, bend over to facilitate exhalation. Because what's the problem here? The elasticity of the pulmonary tissue has been compromised. The rubber bandiness of the pulmonary tissue, which is necessary to pull that thoracic wall in, is no longer as robust, and therefore exhalation can be a very, very long and laborious process. You should be familiar, we'll talk about this later, you should be familiar with the concept of total pulmonary ventilation. In many respects, this is analogous to cardiac output. It is simply the product of the number of breaths per minute times the tidal volume. And remember, we're going to assume the tidal volume is about a half liter. And of course, your patients will breathe at various rates, depending upon a variety of circumstances. But if your patient is breathing about 12 times per minute and has a tidal volume of a half liter, then that's going to come out to about 6 liters per minute. And that's a fairly representative number in a healthy adult. Now, that's total pulmonary ventilation, also called minute volume. So minute volume is really analogous to cardiac output. Perhaps a physiologically more useful measure is alveolar ventilation. And alveolar ventilation is simply minute volume corrected for the volume of the conducting zone. Alveolar ventilation, and you can see the typical abbreviation there, is simply minute volume adjusted for the volume of the conducting zone, which is called, in the vernacular, anatomic dead space. So let's assume, and we'll make this assumption, that your tidal volume is about a half liter, right? And the volume of the conducting zone is about 150 mils. Well, then that's going to leave us with about 350 mils. So instead of multiplying the number of breaths per minute times 500, you would multiply it times 350. And so that would give you about 4.2 liters of air exchange. So alveolar ventilation is simply a more useful construct physiologically because remember, the conducting zone does not contribute to gas exchange. So in alveolar ventilation, we're only including that component of the respiratory anatomy that contributes to gas exchange. That concept, too, is a little bit simplistic to the extent that in the lungs, especially as you're sitting there in a somewhat compromised posture, there are regions of the lung that are not actively regions of your healthy, normal lung that are not contributing to gas exchange, simply because the alveoli, that portion of the lung, is compressed, can't inflate fully, or there may be other reasons. All right? So you should be aware of the fact that in addition to anatomic dead space, which is the volume of the conducting zone, there are, and most all of us at any given time, regions of physiologic dead space. And that physiologic dead space generally includes, and I think I have the word there somewhere, atelectic regions of the lung. The clinicians and the physiologists make a bit of a distinction here. In general, when we talk about medical atelectasis, we're talking, for the most part, about alveoli that are collapsed or they're not contributing to oxygenation of the air, oxygenation of the blood. But a physiologist would argue that any region of the lung that is not perfusing the pulmonary blood is atelectic. I just alert you to the fact that in your pathophys and later Atelectasis normally refers to collapsed or non-productive alveoli. The emphasis is upon the airflow, not the blood flow. So when you breathe in, when you inhale, of course, what's happening is those terminal bronchioles are conducting the air into the respiratory bronchioles, and there's a little acinus or respiratory unit there, the little grape-like cluster of alveoli. Those alveoli are inflating as you increase the volume of your thoracic cavity. And then when you breathe out, and this is what I want you to think about, the alveolus, as it gets smaller and smaller as you breathe out, does it ever collapse completely? Does it ever? As a rule, it shouldn't. We've learned that in some marine mammals it does. We don't think. But one of the problems, and this is what I really want you to think about, because what's gluing the visceral and the parietal membranes together? What's the glue? Basically, just the hydrogen bonding of the water, that serous fluid in there. All right. When you agree that there's a watery film inside the alveoli, as those two membranes come closer and closer together, what should happen or what could happen, especially in a sort of a flaccid alveolus? Yeah. And so if that happened, they would effectively be united by means of that same force that we said is so critical for keeping the two pleural membranes together. So to prevent that, the physiological, the little chemical or substance that is used to minimize that collapse of especially the smaller alveoli, is something called surfactant, surface active agent. You have it in the shampoo you put on your hair this morning, the detergent that you use to wash your dishes. But this surfactant is simply reducing the hydrogen bonding or the surface tension in that aqueous film that lines the alveoli. Now we have something here, and if that's true, there's something called Laplace's law with which you should be familiar. I sometimes have trouble with this, and that's the reason for the left term, I've spelled it out. It's normally Laplace's law is just P equals 2T over R. But I want to make sure you understand that the P here, the P on the left side, which stands for pressure, very explicitly is the air pressure needed to keep an alveolus open, to keep it patent. And so what this use of Laplace's law is telling us is that there is a direct relationship, T stands for surface tension, between the air pressure needed to keep the alveolus open and the surface tension present in the film of that alveolus. In fact, its air pressure is proportional to twice the surface tension. And the air pressure needed to keep the alveolus patent is inversely related to the size of the alveolus. So if that's true, does a small alveolus require proportionally more or less air than a large alveolus? According to Laplace's law, proportionately more or less. This is in the denominator. Smaller the size will require proportionally more pressure. So be aware of those two components of Laplace's law. As the surface tension is increased inside the alveolus, more air pressure is needed. And as the alveolus becomes smaller, proportionately more air pressure is needed to maintain patency.
Sorry, but to go back to 15.
What is 15?
Or slide 15.
I don't have it back.
When you were talking about physiological dead space and you're mentioning atelectasis.
So where are we here? Yes.
Wouldn't that be a pulmonary shunt rather than a dead space?
So what are you referring to?
You're saying atelectasis, and it looks like the wording is saying you're calling it dead space.
Well, first of all, I'm talking about physiological dead space here. So I don't think I fully understand your question, but respiratory disease, poor posture, impaired perfusion. And so
when you're saying regional atelectasis, wouldn't that be a shunt over the dead space itself?
Perfusion is more related to a shunt than it is dead space. That's what you're trying to say.
Is this what you're talking about?
Where the bottom part, where because of regional atelectasis,
Yeah, regional just means a portion of the lung, not the entire lung. That's all that would mean.
that'd be the alveolar collapsing, right?
As in the clinical literature, yes, as we indicated before, because I've had so many students complain about how this term is used, that you should know that clinically in the medical literature, atelectasis purely refers to collapse of the lungs. The emphasis is upon airflow. Yes, from my perspective, we're talking about we're talking about a problem with perfusion of the blood leaving the lungs, because that's the function of the lungs. And that could be for any number of reasons, one of which we'll talk about in a moment, called hypoxic vasoconstriction. But yeah, physiologically, this could happen because of impeded or impaired blood flow or airflow. It's just that in your field, it virtually always means air. It refers to airflow. We'll come back to the local control in just a second. So, is there any question then about Laplace's law? Do we understand the relationship between the surface tension and air pressure and the surface tension and the size? And so, if this is true, if Laplace's law is telling us that there is sort of a direct relationship between air pressure needed, pressure coming into the lungs, and the surface tension, and I don't want to work as hard. Breathing is I'm getting old. I don't care for all the effort and work involved in breathing. I've just had enough. I want to reduce the effort involved in breathing. So how might I do that? Can I change the size of my alveoli? Probably not. I always think of an Italian restaurant. I'd probably change it there. Can I lower the surface tension? Yes. So this surfactant, this surface active agent, which in many respects is acting like a detergent, can be used to lower the effort of respiration. So what we're saying, being silly with the example, of course, but what we're saying is that in individuals with insufficient surfactant, there is, if not the actual result, but the potential risk of respiration or ventilation requiring more effort because those alveoli are collapsing. I know when I took animal physiology back in the 14th century, we were always taught that alveoli cannot collapse, but as I say, there's some recent research indicating that they do collapse in marine mammals, and we don't quite know how they deal with that. In fact, their whole lung virtually collapses when they dive very deep. But they do have surfactant. Now, can you see the little video here? We have, a lot of you probably done this. I find the thumbtacks on my seat quite frequently. The thumbtack is putting on the surface of the water there, and so the individual is adding what? Yeah, adding some type of surfactant or detergent, and watch what happens. Simply illustrating. Oh! There you go. Is that you? Somebody was excited there, clearly. But you get the idea. The surfactant then is lowering the surface tension. That very same surface tension, as we said, is so critical for gluing the pleural membranes together, can be a bit of a problem in the alveoli. Now, where this is going to be an issue for you is primarily, for example, in preemie babies who have insufficient surfactant at birth. The comment I make, I will let it out. So, and just retaining my position. But as a consequence, sometimes supplemental surfactant can be used. It's the surfactant, for example, from cows that can be used to supplement the surfactant is missing. A lot of these, as we've indicated before in our discussion of reproductive physiology, preemie babies present a lot of problems with respect to development. And so there's I think the general opinion now, barring other considerations, you want to allow the child to reach term to avoid inadequate development of the nervous system, the respiratory system, and so on. But surfactant levels can also be impaired in certain types of whatever artificial ventilation may be implemented. I don't know if any of you have been to an oxygen bar Anybody who frequented it, I can put the little tubes up your nose and drift away. They have a number of adverse consequences, but one of the consequences is to potentially lower surfactant levels, cigarette smoking, and then there are a number of respiratory pathologies that can also have adverse consequences. But the thing you want to keep in mind, based upon Laplace's law, is that in all of these cases, this will redound to an increased amount of effort in breathing. Breathing requires more effort if there's an insufficiency of surfactant. Now, as we look inside the alveolus here, this is a dramatically simplified representation, but this would be our alveolus here, all of that sort of gray material. And we can see that the alveolus is right beside a pulmonary capillary here. We can see the red blood cells in the pulmonary capillary, something we'll talk about in just a moment. We can also see, here's our type 1 pneumocyte, or type 1 simple squamous cell that's so important for gas exchange. But this is the type 2 cell. This is the type 2 pneumocyte that is responsible for the release of surfactant inside the alveolus. And this sort of viscid film you see here, it's called lamellar film, is the surfactant that lines the wall of the alveolus under normal circumstances. All right, so much for ventilation. Let's talk a little bit about our objective here as we discuss the physiology of respiration or breathing is to move from the lungs deeper into the move from ventilation to the alveoli. And in order to understand gas exchange, we need to talk a little bit about the composition of the air. I think most of you recognize that most of the air that you breathe is nitrogen. How many of you have your car tires inflated with nitrogen? Yeah. And you're going to tell me, boy, it really makes that car go a lot faster. Well, most of the air is nitrogen. You can see about 78, 79%, depending on how we calculate this. So we're looking at the percentage of air. So we need to talk about the percentages and partial pressures. I do too, by the way. They fooled me. But the oxygen here is typically about 21%. That's kind of surprising, isn't it? About 21% of the air is made up of oxygen. CO2 is in the news a lot because I didn't change this. Notice we're now about 20 parts per million. It's gone up. You can see that we are probably at that 0.04% threshold. It goes back and forth. We're about that level now. And then isn't this surprising? The final percent, if you add all these up, you only get to 99%. Argon makes up about 1% of the atmosphere at sea level. All right. And then over here, by Dalton's law, we have the partial pressures of each of these gases in what we're going to call dry air that isn't humidified. And Dalton's law of partial pressures simply states that the partial pressure of these individual gases, and of course we don't have all of them listed here, adds up to the total atmospheric pressure, which would be 760 millimeters of mercury. So the partial pressure of nitrogen, because it's 78%, is going to be very large, around 593, oxygen 159, and so on. Now, how do we calculate? Somebody quickly tell me how we calculate the partial pressure of each of these gases that are present in the air. How would you do it? Yeah, you would just multiply the percentage times the total, and that would give you the partial pressure. So be able to do that. What you need to, you need really to be able to, you need to memorize these two at the very least, and we'll add to our discussion. I think these are the more recent percentages up here. But that's going to vary with a lot of factors. Now, the air inside your lungs differs from the air out here in a number of ways. Probably the air in here is not the best example. How does the air in your lungs differ from the air that is out here? Anybody have any thoughts on that topic?
It's warmer.
All right, it's going to be warmer, probably. What?
Nitrate of water.
All right, it's going to have a much higher water content. We need to talk about that. And it probably also has a much higher concentration of CO2 relative to oxygen. So those are the three main differences, or several of the main differences. So let's talk about, and you're exactly right, let's talk about physiological air that's more like the air that's inside our alveoli. Now that air is going to be at 100% humidity. So when we talk about air being at 100% humidity on the weather forecast, does that mean that we're breathing water? What does that mean? Does that mean it's raining? All right, so at 100% humidity, the air is holding all of the water that it can hold. If we try to add any more, it's going to precipitate out as rain or some other type of superprecipitant. So in wet air, we find that wet air, 100% humidity is about 6% water, with a partial pressure of about 47 millimeters of mercury. Now you'll notice that as we've added water into our little table here, what happened to all the other partial pressures? They dropped. So make sure you understand that when we calculate the partial pressures, this number is going to be conserved. We're not going to change 760. We're going to keep this at 1 atmosphere and so on. So anytime we add, I guess the better way of thinking about this, anytime one of these gases or substances increases, everything else has to decrease. So if we increase oxygen levels, CO2 levels are probably going to go down. If we increase CO2 levels, O2 levels are going to go down proportionally. So there's a little discussion of Dalton's law of partial pressures. I know some of you are scrupulous adherents of detail. Bear in mind that the actual calculation of partial pressures is much more complicated than is suggested here. For the purposes of our course, we're simply multiplying the percentage times the air pressure at sea level, and that should be a sufficient approximation. And we've also pointed out earlier that the solubility of gases in the blood is affected by a variety of factors. We don't need to get into all of these now. But temperature, we've already talked about temperature, the importance of pre-warming the air that goes into the lungs in order to maximize the solubility of the oxygen going into solution inside the alveoli. If that's not done, if that temperature matching didn't occur, there would be a disequilibrium. In general, it is the case that the relative abundance of the gas in the air will, I guess a better way of saying this, as the partial pressure of the gas in the air goes up, that will also increase the solubility in the water, or in the blood. So as a general rule, the greater the amount of the particular gas above or around the fluid or blood, the more soluble that gas is in the water or blood. And we know, for example, it says here O2 is greater than CO2. Why do I state that? Whoops. What's the relationship between oxygen and CO2 here? Which is more abundant in the air that we breathe? Oxygen, right, 21% or so. So it's 21% versus 0.04%. By the way, pay attention to these numbers. This is not 4%. It's 0.04%. It's remarkable how trivial that number is. All right. But in addition, gases differ in their inherent relative solubility. So it's going to be very important for a discussion later to understand that carbon dioxide is much more soluble in blood or water than is oxygen. Why is your beverage carbonated and not oxygenated? You can go to the gym and get oxygenated water. Anybody had any oxygenated beverages? Make you feel good, feel better. But generally, the beverages are carbonated in part because it's a lot easier to get that carbon dioxide into solution, to get that effervescence that is from the carbon dioxide. Pasteur was one of the discoverers of this simply because the carbon dioxide was so abundant in the fermentation vats that they were using to make alcohol. So these three factors are very important, especially this one. CO2 is about 20 to 25 times more soluble than oxygen in blood or water. Now this figure, this something like this should look fairly familiar to you. We're looking at the lungs up here. We're looking at the peripheral tissues down here. The heart's in the middle. And what we're looking is at sort of a simplistic diagrammatic representation of the flow of blood through the lungs, around and then to the peripheral tissues, and then back to the lungs. So it's simply the cardiological cycle that we're looking at here. Now I want you to pay attention to some of these partial pressures. As we continue our discussion, we're going to be fairly more concerned with the partial pressure of these gases. And you can look over here at the external air. Partial pressure of oxygen is around 159, 160. CO2 about 0.3. If you go back to that table, you'll see that that's the number for carbon dioxide. All right, so you should know that. Just memorize that if you need to. So let's move into the lungs here. Now notice what's happened to can you see that the partial pressure of oxygen has dropped from 159 or 160 down to about 100 or 104. And CO2 partial pressure is all the way up to 40. Anybody explain that? What would account for the partial pressure of oxygen dropping so dramatically?
CO2 increase in water saturation.
Okay, I think you mentioned the primary two components. The CO2 levels have increased dramatically, as remember, according to our Dalton's law of partial pressures. As one component increases, the others must decrease. So, and we lost 10 millimeters of mercury of O2 simply by hydrating the water, simply by taking it up to 100% humidity. If you go back to this graph right here, we went from 159 to about 149 or 150, depending on how you calculate it. So we lost 9 or 10 millimeters of mercury just by that. And then as we add the carbon dioxide, our oxygen level drops dramatically. So not going to be too much of a stickler for precision here, but you should know that in the alveolus, the partial pressure is about 100, 104, something like that, and CO2 is about 40.
Dr. King?
Yeah.
So what happens with the nitrogen? Is it more like a passive
Nitrogen,
bystander?
In most respects, elemental nitrogen is fairly inert. It's only when you start mixing it with when you start creating compounds with it, that you get things like azides and other issues, but it's relatively inert in its elemental form, diatomic form. So you can see, so here's our partial pressure of oxygen and CO2 in the lungs. And what I want to do, then I come down to where it says blood leaving the alveolar capillary. So we're going from the air inside the alveoli to the blood inside the capillaries, or more precisely leaving the capillaries. What's the difference? Is there no difference? And why would that be? Because something we talked about at the very beginning of the semester. Diffusion. What is the principle of diffusion? Everything moves from a region of higher concentration to a region of lower concentration. So in the pulmonary capillaries, and we saw a picture of those earlier as we were talking about the surfactant, in those pulmonary capillaries, the gases will simply diffuse across the membranes according to their relative concentration gradients, and in the lungs they should equalize. So be aware of the concentration, partial pressures of the oxygen and CO2 in the blood leaving the lungs. And then down here, and again, this is a little bit of an oversimplification. It says blood entering the tissue capillaries. Still says 104 and 40. In reality, this is going to drop. This is going to increase for a variety of reasons, but this is approximately true. It's going to be usually in the 90s at this point. Oxygen levels. All right, let's come down here where the tissues are. And it says here the tissues, the PO2 is less than 40 and the PCO2 is greater than 45. Somebody explain that. What's going on in those green cells there? All right, in those green cells, there's going to be oxidative respiration of some type or another, and as that occurs, oxygen is going to be consumed, it's going to be sucked in, pretty much like the air that's taken into your internal combustion engine in your car, those of you who don't have electric vehicles yet. And why is the CO2 going up so high? Why is the CO2 increasing? We've gone from 40 to 45 here. What is the inevitable product of respiration? Yeah, CO2, water, some other things. So yeah. So as the oxygen is being consumed aerobically, CO2 levels are increasing. This is happening in your car too. When you measure the CO2 level at the back of your car, you see that in the exhaust pipe, the CO2 is high along with the CO level, various other things. All right, so let's move over to this one now. It says blood leaving the tissue capillaries. And you'll notice it's about the same. So you need to know these numbers too. So PO2 about 40, PCO2 about 45. And those concentrations are maintained, again in our simplified illustration, until we get back to the lungs, where gas exchange can occur, diffusion can occur in favoring the higher oxygen concentration levels, and we get back to about 140 again. 100 oxygen, 44 CO2.
Fresh air entering the lungs carries oxygen to the alveoli. The amount of gas in air or of gas dissolved in a fluid can be expressed as partial pressure, which is measured in millimeters of mercury. The partial pressure of oxygen in the air within the alveoli is 104 millimeters of mercury. Carbon dioxide that enters the alveoli from the blood causes the carbon dioxide concentration in the air of the alveoli to be 40 millimeters of mercury. Carbon dioxide is continually removed from the alveoli as air is expired. Blood coming from the heart at the arterial ends of the pulmonary capillaries has a partial pressure of oxygen, or PO2, of 40 and a PCO2 of 45. Therefore, oxygen diffuses from the air in the alveoli into the blood, and carbon dioxide diffuses from the blood into the alveoli because of these differences in partial pressures. Oxygen and carbon dioxide diffuse until there is no difference in partial pressure in the air and the blood. At this point, there is no more net movement of O2 or CO2. Therefore, at the venous ends of the pulmonary capillaries, the PO2 in the blood and alveoli is 104, and the PCO2 in the blood and alveoli is 40. Some oxygen was removed from the blood to nourish lung tissue. Therefore, the PO2 in arterial blood leaving the heart is 95. Oxygen diffuses out of the arterial ends of tissue capillaries into the tissue fluid, then into the cells, and carbon dioxide diffuses out of the cells into the tissue fluid, then into the blood because of differences in partial pressures.
We notice the big gradient here. PO2 in the cells is about 20, PCO2 in the cells is 46. Is it clear to you why there would be a difference here? These numbers refer to what's actually going on within the cytoplasm of the cell, because there's going to be a very, very high concentration, high evolution of carbon dioxide, even as the oxygen is being consumed. But as we move into the interstitial region and then eventually into the pulmonary capillaries, that gradient is buffered. And so eventually when everything equilibrates, you're left with the numbers that you see there in the middle.
At the venous ends of tissue capillaries, the PO2 in the blood is equal to the PO2 in the tissue fluid, and the PCO2 in the blood is equal to the PCO2 in the tissue fluid, resulting in no more net movement of O2 or CO2. The blood now carries the O2 and CO2 to the lungs. In the body, all of these exchanges occur simultaneously.
So we have to make sure we differentiate the pulmonary capillaries from the systemic or the peripheral capillaries. All right, I think this was a bit of the source of confusion that we were talking about before with respect to atelectasis and so on. So, and by the way, as we talk about something called hypoxic vasoconstriction in the lungs, it's also called local control, be thinking about our discussion of hyperemia, peripheral hyperemia, both metabolic and reactive hyperemia, see if you see any parallels or differences here. Now, in this simplified illustration, we have a couple of alveoli, and in the representation, the little bidirectional arrows indicate that there is efficient and effective gas exchange between the alveoli and the pulmonary capillaries. All right, and as such, then blood is going to be suffusing or perfusing both of those alveoli. All right, over here we have no gas exchange. So the gas exchange is only occurring along the alveolus on the right side. So what has happened? What has been the response to the flow of, or how has the flow of blood then been diverted? All right, so blood flow has been restricted to the hypoxic alveolus and increased to the alveolus that's contributing to gas exchange. Again, this happens in the lungs. This is happening for a variety of reasons, and this is only one of several processes that is occurring. But the term probably that is best used to describe this is hypoxic vasoconstriction. If a region of the lung is comparatively hypoxic, by that I mean we see that it's insufficiently oxygenated, there is no point, there is no physiological purpose to sending blood to that region. Therefore, it's diverted away. And that's all we mean by that. In the lungs, as in other tissues we've talked about, there are a variety of vasodilators and constrictors. And when we talk about pulmonary vasodilators and constrictors, we're just talking about other substances that would change blood flow. Now, clearly, if we go back to this, we're arguing that oxygen levels are going to modify blood flow levels, oxygen levels in the alveolus. But these should be fairly evident to you. Now, we're going to talk about these three in more detail in just a moment. But we've seen histamine. Histamine is going to depend on the receptor. It can either be a dilator or a constrictor. Adrenergics also can either be dilator or the constrictor, depending upon the receptor. And so we'll talk about, so we've already seen acetylcholine and nitric oxide coming up in this connection. Now we've talked about VQ ratio, and certainly VQ ratio is going to be changed, being altered locally by hypoxic vasoconstriction. Remember in VQ ratio, the VQ in this case, V over Q, we're talking about air over blood. So be sure you know that Q in general can refer to any type of flow, but in this context, we're talking about blood flow. A normal VQ ratio is about 0.8. And you should be familiar with how we derived that, or at least when I say you should be familiar, these numbers should look familiar to you. 4.2, does anybody remember how we arrived at that number earlier?
Yeah, 350.
Alveolar ventilation. Remember, that's our alveolar ventilation. That's the minute volume corrected for the dead space. And this is about the rate at which the blood is pumped around the body. This is the cardiac output. We're going to say it's about 5.5 liters. So it's simply the ratio of air to blood, once again, and typically about 0.8. So that being the case, what would an elevated VQ ratio mean? What would be a typical cause or a possible cause of an elevated VQ ratio? All right, I think I heard both likely options. What were they? So if we, in hyperventilating patients, would that have any effect on VQ ratio? Is it going to go up or down? All right, so make sure you understand that. I think somebody indicated congestive heart failure or something. How is that going to affect cardiac output, VQ ratio? Elevated or depressive? If your blood flow is compromised because it's in the denominator, this number is going to go up, right? So you get the idea. Just be, in very general terms, I'm not talking about clinical pathology here, but just be aware of the types of phenomena that would either elevate or depress the VQ ratio. We're looking at the lungs here. Now look at the VQ ratio at the apex and base of the lungs. Remember, 0.8 is normal. Notice at the apex of the lungs, it's about 3.4 or so. And at the base down here, it's much less than 1. It's down around 0.63. Anybody have an explanation for that? But then as this all evens out, we end up with about 0.8. But I guess maybe a more fundamental question is why would the VQ ratio at the top of the lungs, and remember, let's say in a patient that is standing or sitting, be higher? Let's just make it very simple. Why would the VQ ratio be higher in a standing patient at the top of the lungs than at the base of the lungs? All right, so explain gravity. Gravity is affecting what?
It's going to pull the blood down so that the blood's higher on the bottom of the lungs.
All right, so you're saying there's proportionally more blood here at the base. And I think you're right. But what that also means, there's proportionally more blood and proportionally more air up here. Remember, as we looked at those pictures of the pulmonary capillaries, the alveolus, remember again, sort of a simplistic idea, but that pulmonary capillary was completely wrapped around the alveolus. Now, let's say we're down here. How is this relationship going to change between the pulmonary capillary and the alveolus and the standing patient at the base of the lungs? Is blood pressure going to increase or decrease down here relative to the top? Increase, and that's going to compress the alveolus, and that would account for the diminished ratio of air to blood. Again, this is the blood and air. At the top of the lungs, on the other hand, where the blood pressure is much lower, the alveolus is going to be larger, and in fact, the alveolus may actually be so large and be so compressed together because of the hyperinflation that blood flow may be restricted, may actually be cut off in certain regions. So that accounts for this. You're right, it's largely gravity. Air is also affected by gravity, but blood much more so. So is it clear to everybody why you would have a higher ratio of air to blood up here and a comparatively higher ratio of blood to air at the base of the lungs? Just a few general points to help us transition to a discussion of gas exchange. As pulmonary blood vessels tend to constrict in response to hypoxia, we've already seen that that's hypoxic vasoconstriction. If the blood has a very high concentration of CO2 compared to oxygen, that will also result in compensatory vasoconstriction. And we're going to find that these two are related. So this is, for example, when we talk about the acidity of your soft drink. Why is your Coca-Cola so acidic? Well, the main reason they chock it full of benzoic acid, phosphoric acid, and so on. But they also, CO2. Why is global warming a problem for the little creatures in the ocean?
Acidification of water.
Where we talked about earlier, the CO2 levels in the atmosphere goes up. That's the relative abundance. More diffuses into the ocean. Let's say you have a cousin or uncle who is a dinoflagellate or a silicate, little bitty thing with a calcium carbonate or silicate shell. What's that more corrosive, acidic seawater going to do to their? By the way, it's called a test. It's not called a shell or theca. It's going to wear it away, erode it. So times are tough. But you get the idea. We'll talk more about this called Bohr's law or Haldane's principle a little later. There is something called pulmonary vascular resistance that's similar to total peripheral resistance we talked about before, but for reasons that if we have time we'll talk about, the pressure gradient in the pulmonary circuit is much, much lower. So PVR is, in absolute terms, much, much lower than total peripheral resistance. And then these principles are all the same down here. With respect to pulmonary capillaries, vascular resistance is going to be a function of the size of the vessel, right? The diameter of the vessel. We talked about Poiseuille's law. Everybody remember Poiseuille's law? Radius to the fourth power, exactly right. Where do we encounter precapillary sphincters? Somebody was talking about a shunt earlier. What do we encounter in precapillary sphincters? Remember, these have the ability to divert blood away from the capillaries toward larger vessels in the capillary systems. And then we'll talk about this later, viscosity of blood. Viscosity of blood is the function of a couple of things, but primarily the proportion of red blood cells in the blood. All right, we're out of time. We'll pick up there on Thursday.